We are moving on to the last debate. Professor Mufti, why do you want us to stay with monotherapy for high-risk MDS? Please convince us.
Thank you very much indeed. Thank you for asking me to participate in this debate. I'm a nice guy, I think, but I was talking to Moshe and he told me I have to be aggressive. It's not in my nature, but I'll give it a go. Some might argue otherwise. So let's just, how do we go forward? Okay. So I just want to show you this slide because I think there are lessons to be learned in MDS from this particular slide of AML. Because as you can see, in AML, we had this period of 30 years where there wasn't any drug development. Similarly, in MDS, it's 21 years when Pierre Fenot presented in this ASH meeting the azacitidine trial, and that was a very well-conducted trial, not because people like myself had something to do with it, but it was the randomized trial comparing 5-azacitidine against best supportive care, RSC, and intensive chemotherapy, and the endpoint was not any Mickey Mouse endpoint, but endpoint was survival. And there was an overall survival advantage of 9.1 months. And that is why this drug has withstood the test of time, although I still have the regret that we don't exactly know the mechanism of action of this particular drug. So somebody will have to convince me that there is a similar overall survival advantage in comparison to all the other treatments we have for me to be convinced that we should add another drug. Now, it's the new kid on the block has been venetoclax. It's not quite new, but in the context of acute myeloid leukemia, there is that evidence that there is an advantage when you use azacitidine in combination with venetoclax. And that is why it's been finding lots of partners to try and see whether we can improve on the result that is shown on the slide here. The problem is, there is, to my knowledge, no such data in case of MDS, high-risk MDS or intermediate-risk MDS. Now, my colleague in a minute will probably show you some data from reputable journals, and they will give a better either CR rate or a CRI rate, or a bone marrow remission, or bone marrow remission with incomplete recovery, and all those things in a number of trials. And I'll leave it to you to decide whether this means anything when you have a higher CR rate or a response rate, whatever response rate means, when it is not associated with, in particular, an overall survival in advantage, particularly when it's not been compared with the standard of care, in this instance being 5-azacitidine. So you will hear some of these figures which are at the bottom in more detail, but to my mind, these figures tell you a story that has been told before in a number of diseases, particularly the lessons that we learned from anti-CD47 in the context of acute myeloid leukemia, where again at this ASH meeting there was this huge enthusiasm about magrolimab, only to find out a few years later that there was the trial did not succeed, and as a result the drug was discontinued by Gilead. So the moral of the story for me is that to do randomized trials, and also I would suggest to have overall survival as the endpoint. If that's not enough, what we don't know is what is the right dose. Some people will use 5 milligrams of some people will use 1 week of venetoclax, 2 weeks, 3 weeks. Initially, it was used 21 days. And now, more recently, there's been a study that has shown that decitabine can be used once a week with venetoclax, recently published in Blood. So, to my mind, there isn't still the consensus on what is the right dosage that should be used, particularly in the context of high-risk MDS. And then because of the cost implications, there is this issue of, let's use a CYP3A inhibitor. And if you use a CYP3A inhibitor, you drop the dose to 100 milligrams, but CYP3A inhibitor and the amount of drug that you have available is unknown. And it is unclear whether you have given the right kind of dosage to individual patients. So for me, therefore, the other point is that patients over the age of 70, 75 receiving venetoclax in combination with, say, 5-azacitidine, they do have more cytopenias. They are admitted to the hospital regularly with infections, and consequences of cytopenia are much more. So this is all the more reason to be absolutely certain about the right dosage that has got to be used. And then, as I have said before, that we need to show that when we combine it, even if you support patients during the cytopenic phase, that you can achieve CR, and that CR, MCR, is translated into survival advantage. Now, the other thing is that we know lessons from CLL in relation to venetoclax has been that lots of patients over a period of time will get mutations, and that's been the same with acute myeloid leukemia. We don't know whether it applies to MDS. Of course, it should apply to MDS, but we don't know how often and how relevant it is. So I had my final slide. It's not that I'm against any venetoclax or agents like that. It is the fact that we have not got enough evidence clinically to show whether there is a survival advantage, and if so, is that ubiquitous in all high and intermediate risk patients. I'm not against BCL2. I published a paper 24 years ago, on how BCL2 was abnormal and the abnormalities that occur in it. It's not a question of being against it. It's the fact I don't think the evidence exists. And also, I think we have lost the appetite for doing randomized trials with overall survival as an endpoint, rather than, I would use a crude word, these survival endpoints that kind of sometimes get a paper in the press. So I'll stop at that, see what my learned friend has to say. He told me I'll make you laugh, and I present, and I told him I'll make you cry. So there we are.
Thank you, Ghulam. So Ari Giagounidis thinks that you are too conservative, and he would like to tell us why. Ari.
Thank you, Chairman. My dear Dr. Mufti, these are my disclosures. I've been discussing different things with pharma companies in the past and the present, and I have taken the liberty of changing the title of my talk to Combination Therapy with Azacitidine or Splendid Isolation. Now, for all of you who are unfamiliar with the term of splendid isolation, this comes from Britain. As Dr. Mufti comes from Britain, I want to refer to this. This was the British national policy from 1847 to 1914, and the British tried to keep out of all difficulties and not to mess around with politics in Europe and internationally. Now, as you well know, 100 years later, this has been upgraded to 2.0 when the British have done the Brexit. Dr. Mufti, I would like to remind you that this has not aged well, has it? And I wonder why you are now advocating that we should stay on monotherapies, because it has not aged well to get out of the European Union, and I'm going to show you a couple of examples. Look at the development of millionaires in the world from 2013 to 2023, and you see that actually that the UK has actually reduced the number of millionaires by 8%. Even Greece has done better than that, increasing the number of millionaires by 14%, and I assure you they haven't counted me. Furthermore, Dr. Mufti, India has overtaken Britain to become the 5th biggest economy. So I really don't see whether splendid isolation in medicine also should be the way to go. I acknowledge, though, that the history of azacitidine combinations has been a history of sorry failures. And we have recently heard that tamibarotene also, in combination with azacitidine, has not been very successful. But with venetoclax, it's different. And I agree that we don't know exactly which dose, blah, 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 but here we have a dosage of 400 milligrams over 14 days in combination with standard azacitidine treatment. And the primary endpoint was CR. I agree with that. But there were interesting other secondary endpoints, and not the, you didn't say the word, but I suppose you wanted to say shitty endpoints like marrow CR or something. I am going to tell you that there were also endpoints like marrow CR with hematological improvement, and that's important. And you get a 30% CR rate and a 37% marrow CR with hematological improvement. What that means is that within 2.8 months median time to CR, within 2.8 months you can actually improve the life of the patient. The patient might become transfusion independent for platelets, for red blood cells, etc. Also, we see that the overall survival crossed the line of 24 months. Now, why am I saying this? Because the trial that Dr. Mufti referred to, the AZA-01 trial, showed a median overall survival of 24 months. However, I would like to remind you that at that particular moment, the patients that had been included had a median time of MDS from diagnosis to inclusion into the trial of 12 months. So that was actually relatively stable MDS when they entered and then they were treated. Here we have all comers, and when you look at the CR rate, at the patients in CR and in marrow CR with hematological improvement, they do really, 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 really well. Also, you see that the post-baseline transfusion independence for platelets is 72%. And you all know those patients that come to us and are transfusion dependent for platelets and have high-risk MDS. And you don't know where to get the platelets from and when to transfuse them, and then you have a bank holiday, and then it needs to be done before, and then they need to come directly after, but you know, all this kind of stuff that we encounter. You have a red blood cell transfusion independence of 62%. And the combination of RBC and platelet transfusion independence of 57%. So these are strong numbers. And when you look at the subsequent therapies in this phase 1b trial, 40% of those patients actually underwent bone marrow transplantation with a median time to transplantation of 4.8 months. So you have the time to actually get ready for transplantation, prepare the patient, and then get into a curative treatment. So I would like to finish, Dr. Mufti, with a quote of my namesake Aristoteles from 322 before Christ, who said, "I physis prosto veltio norma," which means nature always strives toward the better. And I tell you, Dr. Mufti, it's better to combine things, and it's better not to do Brexit, and it's better not to stay in splendid isolation. Thank you very much.
Yeah, I think my learned colleague, who is my great friend of many, many years, played here what a very good comedian does. that he plays with the facts and presents them as if they are real. The fact of the matter was that you cannot show me a clinical trial that has actually compared 5-azacitidine on its own versus 5-azacitidine and venetoclax even at a dosage of 400 milligrams and shown that this marrow CR translates into survival advantage. Point number one. Point number two.
You are being aggressive, Dr. Mufti.
I've been asked to. I was instructed by the chair to be aggressive. I'm acquiring fast. The second point is that when you look at those patients that had a transplant, it was the graft versus leukemia effect. You might have forgotten that conveniently. In 60-odd patients, that increased their survival. It might not have been your beloved venetoclax in combination. So unless you show me this randomized trial, I'll never be convinced, and I'll continue to Brexit it.
Last word, Ari.
Obviously, it's going to take a few years until we have data that compare AZA plus venetoclax to azacitidine. But I'm not showing you numbers, Dr. Mufti. I'm showing you patients. And in your daily routine, you will see the patients who come in with a platelet count of 52,000 or 25,000 with a hemoglobin of 8.9 with neutrophils of 300 or 280 for that matter, so that you believe in mold infection, etc. And those patients improve suddenly with the addition of venetoclax to azacitidine, and that's patients. The gentleman a couple of minutes ago asked, you are talking about the syndrome. I want to talk about the disease, and that's exactly what I'm doing, Dr. Mufti. I talk about emotions. I talk about redo the Brexit. Ask the patient, ask the people to vote again, Dr. Mufti. Don't leave the European Union. Stay together. Be a community like we are here. Dr. Mufti, you have failed.
Last word.
That was now emotional blackmail, as well as a comical extra. So I think to state that individual patients should be treated in XYZ manner, that requires objectivity. And objectivity is missing because...
I am Greek, Dr. Mufti. I'm Greek. There's no objectivity in me.
Thank you very much indeed. Thank you very much indeed. No more. No more.
Thank you so much.
Thank you.
Let's go.
Okay, can you flip the slide? I'd like to thank everyone for attending today. This has been a very rich discussion. And we have Dr. Middleman to thank for that. He put in a tremendous amount of effort and brought together very dynamic speakers. Thank you, Dr. Middleman. And to the MDS Foundation, Dr. Neimer, Leah Harrison, thank you so much. Please complete your post-test evaluation to claim your CME credit. Next slide. And don't forget to join the MDS annual or biannual meeting, next slide, with us in Rotterdam, and you can use the QR code to register. Why don't you go back to the CME slide and leave that up with the QR code? Thank you all and enjoy your meeting.